talk is very interesting. It's a new progressive IOL innovated by Dr. Jagdish Kakadia and Dr. Ramesh Shah. Dr. Jagdish Kakadia is going to talk about its science of the autofocus lenses.
Jagdish, the person who is standing is a genius, you know. So listen to him very carefully. He has developed so many machines and so many that this new lens is by him only.
Thank you very much, sir. I am honored to present this talk on the behalf of Dr. Amul Sahu, Dr. Buramani, and Dr. Ramesh Shah. We all are together in this research, and we do have a financial interest. Autofocus Pro is an IOL which looks like monofocal but works like multifocal. It is an aspheric polyfocal intraocular lens with vertically progressive optic, just like the optic of your spectacle lens. Varifocal spectacle lens without any diffractive rings. It is static and fixed in the bag. There is no mechanical pseudo accommodation, and yet it gives you an accommodation of up to 3.5 diopters. This is how it looks. It's almost you cannot perceive that it's a multifocal lens, but if you do an aberrometry on OPD scan or on eye trace, you will notice the progressiveness. Autofocus progressive lenses, this is achieved by green technology, that is gradient refractive index. So there is no loss of light energy like in the diffractive rings, and there are no photons which are lost. This is the schematic optic. Upper half, upper 60% is for distance, then intermediate, and then near. And here you can see that at any size of the pupil, the ratio of distribution of the light always remains the same. And these are the two dialing holes which are also position indicators to be kept in the upper half of the eye. They also help to drain out the retro IOL visco. Because this is a vertically progressive lens, we have to orient it in horizontal position, and the two dialing holes has to be in the upper half towards the 12 o'clock position of the eyeball. And the serrated zigzag L-shaped haptic which are inspired from the postal stamp, they engage so well in the fornix that there is almost an impossible rotation after the implantation. And its optic is unique. It's 7.5 millimeters horizontal and it is 6.3 millimeters vertical. So it covers the entire field of vision without leaving any of the zone aphakic, and it does not give rise to the edge shadow on the nasal retina, and hence it is completely free from the negative dysphotopsia as well. Let us see a short video of implantation of the Autofocus Pro. This is designed by Optics, manufactured by Lifeline. Please notice the two dialing holes and the zigzag outer edge of the haptics. It is a foldable lens made of hydrophobic material which is presented in water to prevent the glistenings. Zigzag outer edge of L-shaped haptic gives excellent stability. It's very easy to fold and easy to fold the haptic as well. It will need at least 2.6 millimeters incision because it's large in size, so it won't go from incision less than 2.6. It's easy to insert the leading haptic as well as the trailing haptic into the bag. And with Sinskey hook we can dial the IOL, and when we dial, the serrated edges of the haptic clean out the fornix base, and you can see that all the lens epithelial cells are scraped out and it comes out as a debris. The two holes have to be kept in the position of 12 o'clock. Once again, to repeat, this is important because we have to keep the lens, since it's vertically progressing, we have to keep the two dialing holes in the upper half of the eye. And when we do the irrigation and aspiration of the anterior visco, anterior to the IOL, you can see that there is no rotation. Even while doing the retro IOL visco removal, you will notice that there is hardly any rotation. There is no rotation at all. It stays where you put it. You can dial it with Sinskey hook, but once your Sinskey hook is out, it will stay exactly where it is. It's stable even while we nudge the IOL. and it remains stable even when the eyeball is nudged with 2 stick sobs. No matter how much force you do, whatever nudging, whatever forceful nudging or gentle nudging, it will not move. It's a rock solid rotational stability because of the special haptic design. And these two pictures taken apart a month shows you a concrete-like solid stability. And at any size of the pupil, you can see that ratio of distribution of light for distance, intermediate and near remains the same, so it is pupil independent. The typical refraction, this is very interesting. After the surgery, next day or day after, when you over-refract the patient with anything from +1 to -3.5, the patient's vision will remain same, 6/6 or 6/9. That gives you the amplitude of accommodation. And the nearly flat curve on the DOF on the minus side gives you an indication, it gives us a confirmation that this lens has a pseudo accommodation exactly mimicking the natural human lens of a teenager, and contrast sensitivity is as good as a young adolescent as measured on Pelly-Robson chart. And the MTF function, which is the indicator of the quality of image and the quality of contrast, Autofocus Pro has 72% MTF function. Monofocal lens, aspheric monofocal lens has a function of 80%. And all the multifocals do not go beyond 45%. So this is working, I mean, giving the image quality which is nearly like a monofocal lens. The normal anatomical variations of size and shape of the pupil and position of the pupil doesn't make any difference. So angle alpha or angle kappa has no importance. And there's no optical noise as it is in a diffractive ringed IOL. Hence, it is free from the neuroadaptation. As soon as you put it, next day morning, the patient is reading 6/6 and 6 and computer by 6. Beyond cataracts, it is also the best choice for surgical treatment of presbyopia, hyperopia, and high myopia, as well as for the closed angle glaucomas. Out of more than 5,000 implanted by a group of 65 of us in last 3 years, not a single patient has complained of negative dysphotopsia. Because of its size, even in a dilated pupil, you cannot see the edge of the IOL. And even in a traumatic mydriasis like this, the IOL border cannot be seen. So this is the reason why it is free from the negative dysphotopsia. And because of its large size, this lens is an ideal choice for various types of natural iatrogenic or traumatic colobomas, and for the mydriatic pupils induced by acute narrow-angle glaucoma or by trauma. It is also the best choice for kids because these children, they have their progressive myopia. They don't want to wear the bifocal glasses in the school. So the parents have to keep spending on progressive chashma, which is around 8,000 rupees. They have to spend at every 6 months or at every 8 months. Whereas with Autofocus Pro, even if they have to use the glasses, it will be only plain monofocal minus glasses which they have to, but never bifocal, never progressive. It has a very sharp square edge, double square edge ring, so the PCO rate is as low. This is 30 months post-op, and you can see that the posterior capsule is very clean. This is the simulated vision of Autofocus Pro. So there's hardly any glare, any halo, so it can be implanted in night drivers also. This is the box design. And all other IOLs are gems, but the Autofocus Pro, I would say, is the jewel of the crown. Please visit us either at autofocuspro.in, our website, and it is launched in this conference, so you can visit our booth 109A and learn more about Autofocus Pro. Thank you very much for your patient listening.
Yeah, thank you.
Thank you, Dr. Kakadia, sir. You are in many ways Leonardo da Vinci of Indian ophthalmology. You keep on doing something new every time you come.
I have used around 50 lenses and I can vouch for it. The presentation will come in the next conference.
Thank you. One difficulty. Can I ask one difficulty? Right, sir, please. See, this, if I compare the lens which you are talking with our spectacles, say progressive or trifocal, when we look down from the lower portion, our eye moves down, and so we see through the lower portion. But here, you are putting the lens inside, can I? Yeah,
Not
I would like to answer that question. Can I? Sir, do I have a time
Yeah.
to answer
Yeah.
that? Huh.
When the pupil constricts, when it really constricts, I'm afraid that whether my lower segment, where you are having the near anchor, it might go inside and I don't have near vision.
Oh, okay. Can I?
Yeah.
Okay. So the first question is that what happens if the patient looks up or down? Now the answer to this is that when the patient wants to read, this macula and the brain will find the finest point of focus. So the eye, if you carefully observe, when the patient is reading, the eye moves about a degree up in order to bring the lower segment in a usable area. When the patient is looking at distance, when you are refracting for distance, the eyeball goes slightly down. So within a day, the patient learns how to adjust. I mean, it's an unconscious learning of the mind how to adjust to this. And out of more than 5,000, which has been implanted by 65 of us in last 3 years, not a single patient has complained that remove my lens. So you have to really try it. Use few lenses and you will realize that there is no lens in the world which is better than this lens. I can guarantee you that there is no lens which is better than this lens. And this is not the opinion,
Sir,
this
you
is
should
not
give one lens to each person in this hall, sir, for them to use.
Now the answer to this question is that this is a company which is formed by 65 ophthalmologists, investing ophthalmologists. So the company is owned by ophthalmologists, for ophthalmologists, by ophthalmologists. So if we start giving free samples, we will be losing our own money. We are not the business people. But I would strongly recommend that you purchase the IOL, and I can guarantee you that you will not be dissatisfied. That's for sure. None of your patient will be dissatisfied, none of you will be dissatisfied. And the price is 7,500 rupees for IOL, that is including GST. So the net price of an imported monofocal, for the net price of an imported monofocal, you get an Indian progressive multifocal with 7.5 millimeters horizontal optic, which cancels the negative dysphotopsia for sure. So what was the second question, sir?
People constrict.
Right. So when the pupil becomes small, the pupil will not go beyond 1 millimeter, not smaller than 1 millimeter, right? So we have tried this, putting pilocarpine 2%, pilocarpine 1% eye drops, and taking the retroillumination, taking the aberrometry. And I can guarantee you that patient never loses the near vision, patient never loses the computer vision, patient never loses the distance vision.
So the depth of focus would increase when the pupil size decreases. So
Yeah.
you're getting an EDOF effect as it is.
Ramesh, you come here. Because his is the brain, and these two people have made it happen.
You're getting extended depth of focus.
The central 0.9 millimeter has got all the three zones. So that will solve your problem. It has taken almost 3 years to come to this conclusion. No company will be able to produce this lens where 0.9 millimeter has got three zones. That is appreciable.
And the best part is on optical bench, when we test this lens, the modulation transfer function of this lens is very, very close to monofocal lens. In spite of that, it is a multifocal lens. With all multifocal, you never go beyond 45%. This is 72%.
And that too for near intermediate distance. If you do the MTF on a machine, for near intermediate distance, it maintains same almost 70% for all three visions.
In a trifocal, I would say the near vision MTF is 14%. Distance vision MTF is around 25-26%. And intermediate. And the distance is around 40-45%. So, I mean, trifocal is nothing compared to this. Even bifocal, multifocal is nothing compared to this. Once you use 4 or 5 lenses, you will fall in love with this lens, and then with me and RC.
Sir.
I personally do 7 patients a day.
Sir, I have made 3
I do
observations.
7 patients.
You ask him outside, please.